Good afternoon. I think we will uh, get started. Uh, I will forego the usual introduction as to why we show a picture of the Brooklyn Bridge, unless there's anyone here who doesn't know what that is. But the point of it is that this is, we're attempting to bridge advances in basic science with major clinical problems. And today we have a major clinical problem. And I think I pushed the wrong button. Oh, come on. So we've had a series thus far on the broad topic of inflammation, which, as the point has been reemphasized each week, that inflammation is much more complex and involved than its original description by the Greeks, which today we would call more like the inflammation of sepsis. And so today we're going to have a discussion on relationship between cancer and inflammation. And if you peruse the literature as to why this is such a hot topic, which it has been for the past half a dozen years, the evidence that there is an important relationship falls into three categories, which are listed here. The first is epidemiologic. And all of the cancers listed there are associated in not all patients, but in many patients with inflammatory disease, esophagitis, Helicobacter pylori infection of the stomach, hepatitis B and C virus infection, and usually cirrhosis, impaired immunity diseases. Today's topic, pancreatic cancer, which, as I'm sure we'll hear about, is more common in people with chronic pancreatitis, colon cancer, people with inflammatory bowel disease, gynecological cancers, in HPV infection, and many others. That's all epidemiologic. Histopathologic, that is, if you look at the tissue sections, there's inflammation around these cancers, particularly if they are invasive, sometimes in the metastases. But inflammation is a not uncommon finding in the histology of the tumor as seen. And the third is there is clinical association, studies, some good, some not so good, that show that there's some prophylactic drug response when people chronically take anti-inflammatory drugs like aspirin or non-steroidal drugs. And it's claimed in various cancers, and there's more epidemiologic evidence here, that this is protective. Now, there may be additional features, but this is what I come up with as the three main areas that have been described. So if we're thinking about inflammation and cancer, I don't know, here are some of the thoughts that pop up, at least they seem to me, and I've put them up to stimulate your ideas. There's this concept that premalignant tumors can be thought of as being somewhat analogous to a wound. And the healing of a wound involves inflammatory, acute, and chronic processes. And there are inflammatory signals, which I'm sure we're going to hear about, that are present and associated with the cancer. But where do they come from? Are they from the tumor? Are they from adjacent cells, the stroma, other cells, or both, or many? And do we understand how inflammation may it actually facilitate malignant transformation? And of course, can anti-inflammatory therapies prevent cancer? Do they affect angiogenesis, which is an important part of cancer spreading? And if so, how? So these are huge problems. And for all these problems, like with the Brooklyn Bridge, you need a bridge. And so today we have two bridge builders. And I'm going to briefly introduce them to you. The first speaker is Christine Allewine, who received her MD and PhD degree from the University of Maryland School of Medicine. Then she trained in internal medicine at Hopkins, did a clinical fellowship in oncology here at the NCI. She joined the Laboratory of Molecular Biology as an assistant clinical investigator, and in 2016 became a tenure-track investigator through the highly competitive NIH Lasker Scholar Program. And then Christine will be followed by Pervez Hussain, who is a tenured track investigator since 2009. He received his PhD in cancer biology from the Nehru University in India, was trained as a postdoc at the Swiss Institute of Research in Cancer in Lausanne, and then at the Laboratory of Human Carcinogenesis here. He joined the faculty of the University of Maryland School of Medicine and later became a staff scientist at NCI and then a tenure-track investigator. So we're very indebted to both of you for taking part in this. And we are particularly indebted to a gentleman who represents a patient who represents a remarkable, and we all wish happened more often, therapeutic response to pancreatic cancer. The pancreas, as you will recall, is retroperitoneal. It's sort of deep inside. A physician doesn't palpate it at all. And it happens to be closely associated with many nerves, with major blood vessels, and with the bile duct, the major bile duct, the common bile duct. And symptoms which are related to those processes are usually very late during the course of the disease. Pain from involvement of the nerves or the bone, back pain in particular. Sort of weakness, weight loss, and so forth related to further destruction of the pancreas and limitation in pancreatic enzymes and digestion and so forth. Or, as you'll hear, fortuitously, obstruction of the bile duct producing jaundice, which is self-evident and maybe an early manifestation if one is fortunate. Many patients have involvement of the blood vessels, which makes surgery and other approaches very difficult. And to compound things, we still don't have screening tests that can be done on blood or some other readily available tissue to determine the presence of pancreatic cancer, particularly in an early stage. And treatment, except in situations which you're going to hear about very shortly, is not very satisfactory. One doesn't speak of cancer as necessarily a good disease, but this is surely one of the worst. So, Christine?
So can everyone hear me? So we're going to talk a little bit about pancreatic cancer and your experience with pancreatic cancer. And did I turn this on?
I turned it on.
Okay, good. And so when you were first diagnosed, what were the symptoms that brought you in to see your doctor?
I walked into work one day and one of my colleagues noticed that I was jaundiced. Pointed out, "You're yellow." Did not use the word jaundice, of course. And I said, "Oh, I'm yellow. I hadn't noticed." And I hadn't. And that sort of started me on the roller coaster.
So I imagine you went in to see your doctor, and what did they say? What did they recommend to begin with?
Well, of course, they did the normal bloods and basically couldn't rule anything out or in. I had been to see my primary care physician prior to that and said, "Tom, do I have gallbladder disease? There's something going on there." And he said, "No, you don't fit the profile." And we were joking about the profile, fat, 50, female, and fertile. He said, "You just don't fit it. I'm sorry. I can't rule it out, but I can't rule it in either." I said, "Okay, wonderful. Where do we go?" Threw up his hands. We eventually ended up being admitted through an ER in Howard County, and then the real interesting part began.
So once you got admitted to the ER, did they take CT scans or MRI scans or any kind of scans of the abdomen to see what was going on, or did they do an ultrasound to look at the gallbladder?
Yes, a combination of the above and everything inconclusive.
Okay. And so then what was the next step with figuring out what was going on?
Well, we did a GI procedure, which was inconclusive.
So did they put you to sleep and
Yes.
they had you swallow the scope?
Yes.
And then so they did the ERCP,
they did the ERCP.
cholangiopancreatogram? Okay.
Yes.
And so they still couldn't decide.
Yes.
So
Nothing.
Were they able to see the tumor on the
Yes,
scopes?
they were.
But then when they tried to take a biopsy of it, the pathology came back
Inconclusive.
Okay.
I was Mr. Inconclusive.
And how many times did they do that procedure where they had to put you to sleep and put a needle
Well,
in?
twice. They did two different versions. The second was performed at Hopkins about a week before the next procedure, which we'll talk about. And the scrapings came back inconclusive. You have the pathology report.
Yeah. And so with all this inconclusive data and someone seeing something that looks maybe like a tumor in that area of the body, what was the next recommendation?
We went off the edge of the cliff. The Whipple was recommended.
And so that's a really difficult surgery. I'll talk a little bit more about it during my talk, but I mean, it's a surgery that's a multi-hour surgery, considered one of the most extensive and difficult, complicated abdominal surgeries that you can do. And it carries a significant risk of not only complications, but death, even up front, just from going for the surgery. And this is for something where no one was really sure exactly what it was. So that must have been a really tough decision about whether you wanted to do that or not.
Well, the interesting part about that, I kept trying to get someone to tell me what the Whipple was, and they talked about the Whipple, the modified Whipple, the various procedures they could do, endoscopic Whipple. And they made it sound like it was just slightly worse than a haircut. No one would come out and explain just how life-altering that particular surgery was and would become, you know. So.
And so you went and you had the surgery, and how long did you have to stay in the hospital after the surgery?
I was in for a week.
Okay. And were there any complications right then from the surgery that anyone was concerned about?
None whatsoever.
Okay,
I
so
was fortunate.
Things went really well. Okay. And then it sounds like, though, that long-term recovery from surgery has not been what you were led to expect.
I have no abdominal muscle left. I have no core. That's disappeared. Functioning is at a relatively low level. I have other sequelae that happened as a result of other procedures, but the Whipple really does change your life. So I would highly suggest that you talk a little more strongly about that, not to scare people off, but realistically, it is life altering.
Now, there are some things that we think about as that can be associated with pancreatic cancer. One of those is diabetes. Did you have problems with your sugar before?
None.
And sometimes when people have that surgery and they have part of their pancreas removed, they'll have problems with their sugar afterwards. Has that been one of the issues?
None.
Okay. And have you ever been a smoker? That's another thing that.
Never smoked in
Yep.
my life.
And have you ever had pancreatitis where you get severe pain in the center of your abdomen and
Never.
never? Yep. And unfortunately, and that's the story that we hear from a lot of people is that they don't have any of the risk factors that we say are that come with pancreatic cancer. And that's right. So is there anyone else in your family who's had pancreatic cancer? Mm-hmm.
Interestingly enough, I have a first cousin who died of pancreatic cancer at roughly the same age that I experienced it.
And is there anyone else in your family who's had cancer of any kind?
Nobody on either side for as long as we can trace.
Yeah. And so after the surgery, was that the end of your treatment or did you go on from there?
Well, sorry, I've described it as the medical roller coaster. When you get on a roller coaster, by the way, my family's from Brooklyn. The roller coaster in the middle of the ride, you don't get off. So had the Whipple, had a week in the hospital, a couple of months of recovery, and then we went through a chemo regimen, Abraxane and gemcitabine, and then went through that, had some horrible consequences from that.
And what kind of side effects did you get from the gemcitabine and Abraxane?
I went blind, literally. I lost my sight, could not see anything. So I ended up at Hopkins again, and they tried to figure that out, and nobody could quite figure it out. So we ended the regimen early, and just waited to see if my sight would recover.
And it did, which was good.
Thankfully, yes. Not completely, perhaps, but close enough. I can drive. I know I'm safe on the road.
And there was never a good answer for why that happened. Yeah.
None whatsoever. Something to do with stem cells, but nobody had a conclusive diagnosis.
Yeah. It's not a common side effect of either drug. I've never heard of that happening before to anyone. And did you end up having radiation treatment as well?
I did. And again, one of the things I described in our discussion is that no one adequately tells you what the side effects truly are. You may lose a little hair. I went completely bald. I had not a hair on my body. You may experience some peripheral neuropathy. I can't feel my feet still. The GI effects from the radiation were marked, tremendous. And, I'm grateful because I'm also lucky to have gotten out on this side of it. 2 years ago this month, I went through the Whipple. So I'm fortunate, I'll grant you. But this idea of how truly life-altering all of these things are was never brought home.
And so after you finish treatment, how do your doctors keep track of whether your tumors come back or not?
Well, I have a CT scan for the first 2 years every 3 months. And now that I've reached the 3-year point, we're doing it every 6 months. So, and again, my oncologist is at Hopkins, and we really don't have a good standard here because not enough people survive. So we're sort of making this up as we go along.
And there's one tumor marker that we can sometimes follow for pancreas cancer called CA19-9. Was that number up for you before you had the surgery?
Well, I never had it measured as far as I could tell until post-surgically. They measured it for the first time, and it was way down. I don't know what it was before. It's now 10.
Mhm.
It was just 84 post-surgically,
Mhm.
and now it's, again,
Yeah.
10, but they didn't measure it prior to surgery.
And when you came in initially with the jaundice, and you said they did a procedure, did they put in a stent to open up the bile duct, or did the jaundice go away on its own?
Uh, None of the above. I don't
Mhm.
remember them putting in a stent at
Okay.
any point.
And so were you still yellow when you went to have the Whipple?
I believe so, yeah.
Okay. And what else would you like to tell everybody about your pancreas cancer experience?
I'm grateful to be here.
Mhm.
That's my attitude.
How much did you weigh
Mhm.
normally before all this?
Well, I've shrunk a little bit and lost a bit of weight. I weighed about 230, and I went down to 160, in that range.
And now,
180, steady.
so I trust that someone is going to explain to the
Yep.
group what a Whipple procedure is.
Absolutely, absolutely. And I had one other thing I was going to ask you. Did you ever have a blood clot through any of this?
Oh my goodness, I'm glad you asked that question. After one of my CT scans, one of the early ones, post-surgically at Hopkins, uh, somehow reading the CT scan got delayed, and we were driving home. And I get a call on my phone saying, "Stop wherever you are, turn around, go right back to the hospital." Well, we were sort of in no man's land on 95, and I said, "Okay, why?" Well, I had 6 pulmonary emboli. And nobody had ever explained there's this relationship. Nobody ever, all the other stuff.
Mm.
So I ended up being treated for that.
Are you finished with treatment for that, or are you still on blood
I'll
thinners?
be on Xarelto apparently the rest of my life.
And have you had any issues with digestion where you've needed to have digestive enzymes or
I'm on Creon.
Mhm.
Yes, those are the 2 things I take. And luckily, nothing else.
Okay. And haven't needed to take any vitamin supplementations for
None.
everything's good with the crayon.
Right.
That's good to hear. That's good to hear.
Let's see if anyone has any questions.
Well, I can speak up for,
Mhm.
Sure.
you mentioned that a number of the effects of the Whipple were not fully explained to you. Do you, looking back, attribute this to sort of lack of inquisitiveness on your part or lack of forthrightness and as you go through these procedures?
That is an excellent question.
Mhm.
Oh, sorry.
Mhm.
That's an excellent question because I think there's a bit of shock psychologically. I don't think that I'm totally blameless in this at all. My recollection was that the full extent of the Whipple, in terms of both the procedure and the after effects, the consequences of the procedure, I didn't get. And I'm reasonably well versed. I'm not an expert, I'm not a physician, but I understand the biology involved and the anatomy. And I can't tell you whether I was in a state of shock and unreceptive or it wasn't fully explained. I really don't know. I think they go out of their way for informed consent purposes. I understand that. But I don't think there's a real explanation of what happens as a result that truly, and I've used this term before, life altering. You're not the same.
And I think one of the things that you'd mentioned to me was before you actually had the diagnosis from the surgery, where you had the definitive diagnosis, no one had ever mentioned that they were looking for cancer through that entire process.
That is true. No, nobody mentioned the C word.
Mhm.
Everyone was afraid to. When I was first admitted to the ER, because that's the way you gained admission to the hospital, one of the ER physicians mentioned a whole range of possibilities, and he mentioned cancer, and he was immediately pulled aside and told to shut up. So that was the first time, and the last time until I had the Whipple.
Mhm.
So I have a question. In this process, okay, in this process, were you ever really, at what point did they determine that you had cancer of the prostate? Because I know a lot of people, they have never survived that.
Uh, it, and I've
Mhm.
given Christine the pathology report, the surgical pathology report. It wasn't until I had regained consciousness and was fully cognitively aware of my surroundings that anyone came up to me and said, "You have pancreatic cancer."
All right, well, listen, I want to thank you very, very much and wish you continued wonderful
Thank you.
success.
So I'm going to talk a little bit more about the clinical aspects of pancreatic cancer. So like we heard already, the pancreas as an organ is way in the back of the abdomen towards your back side. So as in your back, not your back side. But what you're looking at in this diagram here is the stomach is actually made translucent. It actually sits behind your stomach. And what you can see, so it's a retroperitoneal organ. And what you can see is that the head of the pancreas, this part here that's more towards the center of the body, is actually intimately associated with the first part of the intestine that's called the duodenum. And that if this is your gallbladder here, your bile duct actually runs right through there. And here you see this yellow here is the pancreatic duct, which also empties its contents out into the first part of the intestine as well. So both the bile and the digestive enzymes made by the pancreas are important for digesting food. In addition, as probably all of you know, the pancreas also makes insulin, which is its endocrine function to help with absorbing sugar, and that those things can also be impacted by pancreas cancer or the treatments for it. So the body is this part in the center of the pancreas. The tail is at the edge towards one's flank. And what's one of the strange things about pancreatic cancer is the majority of pancreatic cancers actually occur in the head of the pancreas, more so than the body or the tail. About 75% of them are there. And there's some research now going on to try and figure out why that might be. There are multiple subtypes of pancreatic cancer, but when we say pancreatic cancer without designating a subtype, what most people mean is pancreatic adenocarcinoma, because that's about 90% of all pancreas cancers. There's also another type of pancreas cancer that's not completely uncommon. That's called the neuroendocrine tumors. They have a much better prognosis in general than the most common type of pancreatic cancer, the adenocarcinoma. There are other rarer tumor types such as mucinous acinar cell carcinomas, pancreaticoblastomas, but we're not going to talk about those at all today. We're going to really talk mostly about adenocarcinoma. So this is a list of what are considered risk factors for pancreas cancer. And the first thing that I'm going to bring to your attention is the bottom of this table down here, where they're talking about different hereditary mutations that you could pass on from one family member to another that increases your risk of pancreas cancer. And these are really, in general, fairly rare conditions. There's only about 10% of pancreas cancer patients that have a genetic syndrome that can be attributed to being responsible for their pancreas cancer. So if you have hereditary pancreatitis, where you get pancreatitis over and over again, which is caused by these genes, you have a much higher risk of getting pancreatic cancer, so it's 50 times the average population. Familial atypical mole and melanoma syndrome, which is a P16 CDNK2A germline mutation, greatly increases your risk. The BRCA mutation or PALB2 mutations, which are a DNA damage repair pathway mutations that we usually associate with breast and ovarian cancer, can also increase your risk of having pancreas cancer. Peutz-Jeghers syndrome gives you a much increased risk of pancreatic cancer, as well as HNPCC or Lynch syndrome, which we typically associate with colon or endometrial cancer. And then rarer P53 and ATM mutations can also increase your risk of pancreas cancer. But these are the minority of patients who have these genetic syndromes. There are also a number of patients that have hereditary pancreatitis, as in they have multiple family members who've had pancreatitis who have had pancreatic cancer, in the past, but were unable to identify a mutation that accounts for their pancreatic cancer. And sometimes that's even the case, even though their genes have been sequenced. And yet they have a very high risk in their family. When you talk about the majority of patients with pancreatic cancer, here are what are considered the non-genetic risk factors. So smoking increases your risk 2 to 3 times. If you have long-standing diabetes for more than a decade, sometimes even 2 is what they count for that. Or if you have chronic pancreatitis, which is a very painful inflammation of your pancreas, where you have these episodes, and if you have that repeatedly, that's what makes it chronic. And obesity actually doubles your risk over the normal population of having pancreas cancer. And then there's this having A, B, or B blood type, which no one really understands at this point. But when you look at what the amount of risk that you get from each of these factors, it's very small for pancreas cancer compared to something like smoking for lung cancer, which increases your risk of lung cancer 8 to 15 times. So these factors, they contribute, but it's not a dead ringer like you see with some types of cancer and the risk factors for them. And many patients with pancreatic cancer have none of these risk factors at all, yet have still gotten pancreas cancer. What I want to point out, though, given the subject of the talk, is the reason that these are thought to be factors contributing to patients getting pancreas cancer, the ones that are highlighted by the arrows, they all cause inflammation of the pancreas and a chronic inflammation of the pancreas. And that's what's thought to, in some people, go on to trigger the development of pancreatic cancer. And I think one of the most important things that's really not on this chart as a risk factor is pancreatic cancer is another one of those tumor types that's true for most cancers. It's a disease of aging, and the older that you get, the higher your risk in general of getting pancreas cancer. So we heard a little bit about the symptoms of pancreatic cancer already. One of the most common reasons people are diagnosed is because they turn yellow, they get jaundice. But the other symptoms that might come before that are very hard to pick out as something that we need to do something about right away that could be really serious. So patients will have a tendency to come in with upper abdominal pain or mid-back pain because that's where a sore pancreas feels like it hurts. Sometimes nausea and vomiting, very frequently weight loss, loss of appetite, which we call anorexia, or feeling full quickly, which we call early satiety. And recently, one of the symptoms that's been identified as being one of the earliest symptoms of pancreatic cancer, although very hard to spot, is what they're terming lethargy, which means not only a loss of energy, but also a kind of depression that comes over people even before they're diagnosed. All of these symptoms are things that cause pancreatic cancer, but when you're a doctor and somebody comes into you complaining of any of these except jaundice, there's many other things that cause these that are much more common than pancreas cancer. So it's not, although it's on the list of possibilities, it's not the first thing that comes to mind as, oh my goodness, I need to make sure this person doesn't have pancreas cancer. So how do you diagnose it? Typically from imaging studies, either ultrasound, which I've not shown here, or CT or MRI imaging. What you see where this red arrow is pointing, that dark spot here is a pancreatic mass. Pancreatic cancer is a bit unique. Most solid tumors will show up on contrast-enhanced CT scans as the bright spot in the CT scan. Pancreas cancer shows up as the dark spot. That's thought to be because of its very unique stroma, which I think that Pravesa is going to talk more about later. It's a hypovascular tumor is really what this says. It's really hard to get stuff into this tumor, and it actually has less blood vessels going into it than the surrounding tissue. This is an example of what a pancreas tumor looks like on an MRI scan. Down here, you're looking at what's a cholangiopancreatogram from an MRI image, where they've filled up the ducts with contrast. The green is pointing to the bile duct, and you can see this pear-shaped gallbladder here. And over here, the yellow, this is the pancreatic duct. And it's supposed to be a nice thin line, but you can see that this has got a big ballooning here. And when we see that, this dilatation of the ducts, which you can see on CT scan as well sometimes, it's because there's something obstructing the duct downstream right about here, which makes the fluid in the pancreatic juices accumulate there. So the most typical way that patients who have tumor confined to the area of the pancreas are diagnosed officially, because we need actual tumor tissue to say whether this is cancer or it's some benign tumor or some other process that's going on, is that patients will go on to have an endoscopic procedure where they have a scope. They're put into twilight sleep, and they swallow a scope and goes past the stomach into the small intestine. And sometimes you need to cannulate the bile duct as well to come up and take a picture. That's called an endoscopic ultrasound. And using that, you can either direct a needle biopsy or take brushings of a tumor sample that you see. But as you can imagine, you saw where this organ is. It's way, way in the back. You can't go through the spine to get to it. You have to come through the front if you were coming from outside. So you're doing this inside with an endoscope. The amount of tissue sample that you can get is very small. And it tends to be just a cellular sample or a fine needle aspiration. And it's frequently insufficient to make an conclusive diagnosis of pancreatic cancer. And thus you end up in the situation that our patient was in, where you have something that's suspicious, you have symptoms that suggest it, but you're unable to make a definitive diagnosis because you can't get enough specimen to do that on any of these procedures. And so you end up having to make this decision about whether to go to surgery or not without having a true diagnosis. And many patients are diagnosed from a surgical biopsy. For some patients, many patients already have disease that's spread beyond the pancreas, and they avoid this problem because they're able to have a biopsy of a tumor that someone sees in the liver, which is much easier to get to. And that's what percutaneous liver biopsy is. So how common is pancreatic cancer? So this is some of the most common cancers, and you can see that in turquoise is the number of people estimated to be diagnosed this year with pancreas cancer. So it's about 54,000 people. So that makes it the 11th most common cause of cancer in the United States. However, despite that, it is the 3rd most common cause of cancer death because so many of the people that get pancreas cancer die from it. The only 2 tumor types that more patients die from now are lung and colon cancer. And why is this? So the thing that's most commonly cited as the reason for why this is because most patients have what we call metastatic disease at diagnosis, meaning that their disease is spread beyond the pancreas and has gone to other organs in the body like the liver, the lungs, or throughout the abdominal cavity. And so more than half of patients have metastatic disease at diagnosis, and only 9% have early stage disease. This regional designation that the American Cancer Society is recording based on their epidemiologic statistics is a little hard to interpret in pancreas cancer, and I'm going to show you why in a minute. So what are the barriers to early detection? Why are there so many people that are diagnosed late? So like we talked about, the early symptoms of pancreatic cancer are very general. So there's no red flag that says, hey, here, we have pancreatic cancer here. We've got to do something about it. And most of the time, by the time people get jaundice, their tumor is too big or has spread, and it's not early anymore. The other issue is that even if you have these symptoms and you go for imaging studies, many times the imaging studies have trouble detecting small lesions in the pancreas. It's a hard organ to see as well as get to, and they don't light up. They're dark, and so it can be harder to notice them. And this is, there are no blood tests for pancreatic cancer. There's a tumor marker, CA19-9, which I mentioned, but you can't use that to diagnose pancreas cancer. That marker will go up just when somebody's jaundiced, even if they don't have pancreas cancer. And there's other reasons why it can go up. And it doesn't, if it's 10,000, that's kind of a dead giveaway that maybe it's pancreas cancer. But when it's 84, like we just heard, there's a lot of different things that can make it go up that high. And so this is the problem, is identifying specific biomarkers that point out pancreas cancer and not just jaundice or some other abdominal problem. And so let's pretend that there is one that's very specific for pancreas cancer. And you use that, and this test has 100% sensitivity, meaning if you test 100 patients with pancreatic cancer, the test will come back positive for all 100 of them. And the test has 99% specificity, meaning that if you test 100 people, 99 times out of 100, when it's positive, those patients really have pancreatic cancer, you still run into this issue. And that is that pancreatic cancer is relatively rare. There's only 12 cases per every 100,000 persons. So if you test all of those 100,000 persons, even with a 99% specificity, you will have 83 false positives for pancreatic cancer for every real case of pancreatic cancer, just by virtue of how rare it is. And for some tumor types, other than pancreatic cancer, you can get away with that kind of sensitivity and specificity, and we do all the time. The problem is that the retroperitoneal positioning of the pancreas makes biopsy extremely difficult. And even just to get your first look, you have to do this invasive endoscopic ultrasound procedure. And then in some cases, you're left with the situation that our patient was in, where none of those procedures gave a conclusive diagnosis, and you're being asked to do a very large surgery to figure out whether you have pancreas cancer or not. And 83 times out of every one, you're going to be doing a surgery on something that isn't pancreas cancer, even in a test that has 99% specificity. And so that's the issue, the really big issue with developing tests for early detection in this disease. Now, what I was talking about before with stage at diagnosis and that middle ground is, clinically speaking, we divide pancreas cancer into 3 different categories. We call early anyone who has a potentially curable tumor. So this is stage 1 and stage 2 disease. So clinically, stage 1 disease means it's confined to the pancreas. Stage 2 disease means that the tumor can extend a little bit behind the pancreas, but you can still cut it out by surgery. And you can also have some lymph nodes positive, because you can cut those out by surgery as well. Locally advanced stage 3 means that the tumor is in the pancreas and the surrounding regions, but is not resectable, even though it hasn't spread to other organs. And metastatic stage 4 means it's spread to distant organs. So that grouping of regional includes both stage 2 and stage 3 disease, which clinically speaking, we think of in very different terms in pancreas cancer. So it's hard to know what that regional means when you talk about survival. So if you look at 5-year survival percent by stage, compared to other common, the 4 most common tumor types, pancreas cancer is much more lethal. So there's a 9% 5-year overall survival of all comers with pancreas cancer. And this is actually shockingly an improvement. Just 5 years ago, this number was 5%. It's nearly doubled in the past 5 years. And we have a lot of hope that maybe this will get even better soon. So why is this so bad? And I think if you look at it this way, patients with every tumor type, if you look here in the metastatic disease category, don't have a great survival long term. However, the issue is that patients with early stage disease and pancreatic cancer have a much worse survival than patients with other common tumor types, where a 5-year survival is just 29%. And if you compare that, if you get diagnosed with early stage pancreatic cancer, your chances of living 5 years are approximately the same as if you were diagnosed with breast or prostate cancer that had already spread everywhere at the time you were diagnosed. And what this tells us is that our treatments for early stage disease that we've had up to this point are really not that effective at being able to get people the kind of survival that we'd like to see. So even when we can screen people well, and in some cases where these families that have genetic mutations or familial pancreatic cancer, there's new studies out showing screening methods for those families where the prevalence of pancreatic cancer is so high that that issue with false positives ceases to be as much of a problem. The survival rate that we get is still in this realm, not 100% by detecting what we're calling early. So what is the treatment for early stage disease? So it's surgery plus chemotherapy, and the key piece of this is surgery. And whether something is surgically resectable or not is defined by how many vessels are involved and local structure. So around the pancreas is a pretty valuable area of real estate, and there are a number of very large vessels that run through there, specifically the portal vein, the hepatic artery, the celiac axis, and the superior mesenteric artery and vein. Now, if your tumor is not near or wrapping around any of those vessels, you're clearly resectable. And if it's encasing, for instance, the SMA, the superior mesenteric artery, there's very few surgeons, no surgeons you're going to find that are going to want to resect that. However, which other vessels it's abutting or encasing in between, there is some variability among who your surgeon is, whether they would consider it resectable or not. But the more vascular involvement you have, the more complicated the surgery. It requires vascular patches, that kind of thing. But where this divides off is a frontier of pancreatic medicine right now. So the surgeries are, the most common one is the Whipple, because this is for tumors of the pancreatic head, and like we talked about already, those are the most common. It's a very complicated procedure where if this is the anatomy here, you're removing all the parts that are shown in light blue. And what makes it complicated is not just that you're chopping off these things, but there's a lot of tubes that have to be reconnected afterwards. So here you're chopping off the first part of the small intestine, which means that you have to reconnect the end of the stomach to the intestine. Then when you take out the head of the pancreas, you need to reconnect the pancreas to the intestine as well so that the digestive enzymes can get to the digestive tract. And you have to reconnect the bile duct, which has been taken away as well, to the intestine. And all of these connections make for possibilities of things to go awry. And this is a piece of anatomy that's way back in the back of the abdomen as well. And so it's difficult. So there's a high morbidity and mortality rate with this surgery. The mortality rate nationwide, I was recently heard by a surgeon speaking, said was 7% upfront mortality with this procedure for all surgeries done in the country. When it's done at a high volume center, it has a tendency to be actually closer to 1%. The risks of morbidity, which you're looking at here, are from a recent paper out of Hopkins where there was a surgeon that had been operating and did over 2,000 of these pancreatic procedures over the course of his career and has some of the best morbidity rates in the country. And this is what you're looking at, where you have delayed gastric emptying, fistula, which means things are connecting, pipes are connecting to each other that shouldn't be connected because they erode through. Wound infections from leakage of things with these connections, bleeding, leaks, and sometimes with this being a large surgery and these being older patients, there's issues with cardiac events and pneumonia. There's a long recovery period from the surgery, and there are long-term complications of the procedure, as you heard. The other type of surgery that's done is if you have tumors in the tail of the pancreas, distal pancreatectomy, where the tail of the pancreas and the spleen are removed. It also carries a pretty significant complication rate. And some patients actually end up having total pancreatectomy, which by definition will result in insulin dependence, although that does happen with some of the other procedures as well. So surgery alone is not enough to cure almost all patients. So if you look at these data, this is a survival curve where you start with 100% and you're looking over time on the x-axis. And if you just observe patients following surgery, what you can see is that almost everyone, it's actually 5%, are still alive at 5 years. That doesn't mean their tumor isn't back. That just means that they're still alive at 5 years. What was found in this study is that if you give adjuvant chemotherapy, adjuvant means chemotherapy after surgery, you can improve the number of patients that survive long term. And the reason we think this is because even though these patients had an R0 resection, which means that all visible tumor was removed, microscopically their tumor was removed, that there's still tumor cell seeds that are throughout the rest of the body that had already spread, even though these were early stage tumors. And so you need this drug to go throughout their body to kill these little seeds of tumor. But unfortunately, with the drugs we have, with gemcitabine, we're only able to do this for about 20% of patients who are alive at 5 years. Very recently, there's a new standard of care for chemotherapy to be given after surgery, and that's the combination of gemcitabine and capecitabine. This is hot off the press last month. The data were first reported in ASCO last year, where if you have the perfect surgery and you get this chemotherapy, then it's about a 40% 5-year survival rate, although the numbers at this point, if you look down here, of patients we're talking about are very low because the follow-up has not been this long for a huge number of the patients on this study. But it's very encouraging. And something like this can really make a big dent in what 5-year survival is for this disease. For patients with advanced disease, the standard of care is to give chemotherapy. And these are the lists of all the different kinds of chemotherapy we can give. FOLFIRINOX, which is actually a 4-drug regimen of 5-FU leucovorin, irinotecan, and oxaliplatin, is widely considered to be the most effective regimen, but there's very few patients with pancreas cancer who are strong enough to be able to tolerate this regimen. So when patients in metastatic pancreatic cancer who receive FOLFIRINOX, these are the survival curves again, and what you can see is that the median overall survival getting FOLFIRINOX in these very fit patients is 11.1 months, meaning 50% of patients die before 11.1 months, and 50% of the patients died later than 11.1 months. Response rate means that this regimen was able to shrink a tumor by 30% or more in just 1 out of 3 patients, a little less than 1 out of 3 patients that received it. And that this PFS is progression-free survival, which means that this drug worked for an average of 6.6, a median of 6.6 months in these patients before their tumor started to grow again. So this was a significant advance over gemcitabine alone, which was the drug of choice before. But obviously, we wish that we could do better. And so what are the new treatments that are on the horizon? So we're in an age of precision medicine, of targeted therapy. There's been a lot of the tyrosine kinase inhibitor targeted therapies that have been tried in pancreas cancer. There's a list that you could probably make that would go on for a page, either with or without gemcitabine. And really, none of them have shown any clinical benefit. And this is the mutational landscape when you talk about mutations in cancer, of pancreatic cancer, and it's dominated by KRAS. Over 90% of these patients have KRAS mutation. Unfortunately, we don't have drugs to treat KRAS mutation at this point. And at some point, if we do, pancreatic cancer is the poster child for that type of drug treatment. The other major mutations in this cancer, P53, SMAD4, CDKN2A, there are also no drugs that treat those. And so that's unfortunately the place where we are now, where we really need new treatments that can target these things. The other really hot area of oncology right now is immune checkpoint inhibitor therapy. And in most tumor types, with the new immune checkpoint inhibitor drugs, we see about a 15 to 25% response rate, and patients, even with metastatic disease, having some very durable responses. Unfortunately, in pancreas cancer, that's not what we've seen. The single-agent immune checkpoint inhibitor therapies are ineffective, with the exception of about 1% of patients who have a type of genetic change called microsatellite instability. So there's a lot of research going on right now to try and figure out how we can change this and get these tumors to respond to immune checkpoint inhibitors and other immune therapies. So symptoms of pancreatic cancer, obstruction we heard about, where obstruction of the biliary tract causes jaundice of the stomach or intestine, can cause vomiting and poor nutrition. When this happens, one of the things that's most commonly done is that GI doctors go in, they do the endoscopic procedure, and what you're seeing here is a buildup of fluid in the stomach because there's a blockage. They clear that out, and here you can see the tumor blocking the channel. They are able to insert a wire through there, and then they can put in a stent or a mesh to open that back up again so that what needs to flow through can flow through again. These patients can often have terrible problems with pain because there's a major nerve complex right behind the pancreas, and frequently that pain is resistant to the usual narcotic medicines we use to treat cancer pain. Some people actually need to have a nerve block, which works about 80% of the time to help them with their pain. There's weight loss and associated wasting syndrome with pancreas cancer, which we think is that pancreas cancer, when it's out of control, triggers an inflammatory cascade which causes these things. It's not well understood why that is. And well as nausea and vomiting, diabetes, fat-soluble vitamin deficiency, and blood clots. There's a number of treatments that are on the horizon that are exciting, that hopefully we'll see in the future. One of the open trials right now, phase 3, is exactly the regimen in the adjuvant setting that our patient got, which is gemcitabine nab-paclitaxel, which we know is effective in the metastatic setting, but we need more time to see whether it's effective in following surgery. So this is my summary. It's the third leading cause of cancer death in the United States because many patients are diagnosed at a late stage. Other treatments for early stage disease are not as effective as those available for other tumor types. Early diagnosis is difficult. Pancreatic surgeries are very tough. The available drug treatments are relatively ineffective. Many new treatments are currently under investigation, and the side effects of pancreas cancer and its current treatment have significant impact on patients' quality of life. I was asked to speak very briefly about my research. So I look at mesothelin-targeted therapies for pancreatic cancer. Mesothelin is a surface antigen that's expressed on many cancers, including 95% of pancreatic cancers. And one of the important things about stuff that you target for making drugs for cancer is the cancer has to make a lot of it, but your normal tissue has to make little to none of it. The only place that protein is expressed is the cells that line the lung, the heart, the abdominal cavity. You can kill all of those and someone can go on living just fine. And because it's such a good target, there's a number of these therapies that target mesothelin in the clinic. And the ones that I'm specifically interested in are what are called recombinant immunotoxins. These are antibody-based therapies where you take the binding domain of an antibody and you combine it with a bacterial toxin payload. The toxin that we use is the exotoxin A from Pseudomonas aeruginosa, which is the most toxic substance by weight in that bacteria. And we fuse these two pieces, the catalytic domain of the toxin and the targeting region of the antibody, in frame to produce a single molecule. And the one that you're looking at here is SS1P, our first generation anti-mesothelin immunotoxin. It's been tested in clinical trials, and we also have a second generation molecule, LMB100, which is in clinical trial now. The mechanism of action is that it inhibits protein synthesis. It gets endocytosed, released into the cytosol, and the toxin actually catalyzes the modification of elongation factor 2, which is a critical enzyme in protein synthesis that inhibits protein synthesis because it's irreversible, and that's a lethal insult to many cells. This is a pretty unique mechanism of action that's not true of most other drugs. I have an open study for pancreas cancer patients based on this preclinical data. So we can give our immunotoxin drug in combination with chemotherapy, nab-paclitaxel chemotherapy. What you can see is alone, either the drugs in blue for the immunotoxin or in green for the chemotherapy can temporarily halt tumor growth. But if you give the two drugs together, you can cause complete responses, and these are mice with pancreatic cancer tumors. So you get complete responses in all of the mice. And in many cases, as you can see from the survival curve, the tumors don't grow back even out to 4 months. So we thought this was pretty exciting. And so I have a open early stage clinical trial looking at this combination for patients with previously treated advanced pancreatic cancer. The primary goals of the study are to look at the safety of the combination, because that's the most important thing when you're mixing two new drugs together in people, and to determine whether the combination can shrink tumors better than the chemotherapy alone. And that's the idea. I have a lot of people to acknowledge in my lab, on our clinical team, and my mentors, Ira Paston and Rafit Hassan. And these are the people that paid for my work. And that's the story.
Okay, well, thank you very much. That was a very extensive discussion. Everyone should know about pancreatic cancer. Just a second.
Thank you for your presentation. Besides the standard and novel treatments that sound great, my question is maybe a basic question. How often do you estimate that the patients with the early or curable stage of pancreatic cancer can present those florid symptoms?
So, that's the number. Is it's about 20% or less of patients when they're diagnosed have early stage disease. What percent of those patients went in and had a CT scan for some other reason and somebody found the pancreas tumor versus patients like we heard here who had jaundice and went in and were lucky enough for the tumor to be confined to the pancreas? I don't know the answer to that. But it's about 20% of patients at diagnosis are potentially surgical candidates.
You mentioned that because of tumor structure and pancreatic cancer, drug delivery is more difficult to this. So what approaches are used to facilitate drug delivery to specifically pancreatic?
Absolutely. So a lot of the new therapies are really concentrating on that. And I think that Pervez is going to talk more about that shortly. The microenvironment of pancreas cancer is really unique. And one of the studies which I showed that's now in phase 3 is a trial of standard gemcitabine, nab-paclitaxel, or Abraxane chemotherapy in combination with a pegylated hyaluronidase. The pegylated makes it last a long time in circulation. Hyaluronidase is really what the drug is. And that breaks up, it prevents the formation of some of this gel matrix that turns these tumors into concrete and can open up blood vessels. And it's been, the phase 1 and phase 2 results have been very interesting, showed promise in patients that have high stromal tumors, and we have a lot of optimism for what might be seen in this phase 3 trial. But that's the one that's furthest ahead in development. But there's a number of other strategies that are in the earlier stages of clinical trials.
Okay, thank you very much. There'll be time at the end, but we want to hear Dr. Hussain. I think it's interesting to note that, I mean, pancreatic cancer has been known for a long, long time. And yet research in this area has been very modest up until perhaps the past, I'm guessing, 5, 7, or 8 years ago. There was a lot of surgical discoveries done, including the development of the procedure that our patient had. But by and large, studies of the biology, the diagnosis, it lagged behind, but that's changed dramatically in the past year or two, and there's an enormous effort nationwide and also here at NIH focusing on pancreatic cancer.
Thanks. Thank you very much, Wayne, for giving the opportunity, and thank you, Christine, for teaching us such a comprehensive way the treatment and clinical aspect of pancreatic cancer. And as we learned from Christine talk that there are tumor biological aspects of pancreatic cancer that needs to be understood to make some progress towards identifying the targets that can be used for the therapeutic intervention. So what I'm going to do today is to give us a little bit about the molecular biology of pancreatic tumors and how the inflammatory mediators and the inflammatory signaling pathways are associated with disease progression and aggressiveness in pancreatic cancer, and it can be targeted to achieve some meaningful progress in this lethal malignancy. So as Christine highlighted very well, that it has very poor prognosis because of the late diagnosis and poor therapeutic response. So how we can improve the outcome in this malignancy? So of course, we need effective therapy. We need to identify novel targets, molecular subtypes, because recent studies, and I will show you a couple of slides showing that there are molecular subtypes based on the either gene expression or the metabolic profile or chromosomal structural variations. So we can select the molecular subtypes that will respond to a specific drug. And then treatment can be selected based on the molecular makeup of that tumor. And then drug delivery, as Christine already highlighted, that is a problem in this cancer. And there are some of the studies that are in clinical trial where which targets the stroma and enhances drug delivery in the tumors. So other important aspect, very important aspect, is early detection and also to identify biomarkers for precancerous lesions, not only when a person has tumor, because as you saw, we don't have any good treatment that can be given once the tumor is developed and it is in advanced stage. So to achieve all these, we need a understanding of pancreatic tumor biology that involves genetics and epigenetics, tumor stromal interactions, metabolic reprogramming, and also transcriptional dysregulation. And I will later tell you how inflammation and inflammatory mediated signaling can cover all these aspects of pancreatic tumor biology. So this slide is just to show you that there are different defined precursors lesions in pancreatic cancer, and that are termed as pancreatic intraepithelial neoplastic lesions, and that are divided into 3 types, type 1, 2, and 3. And there are different genetic alterations that are specific to different subtypes, which starts with the telomere shortenings and KRAS mutation, which Christine already described, and then a P16 or CDKN2A alteration, and then P53 mutation and SMAD4 mutation that is late in the progression to carcinoma. So this is to show that there is a prominent desmoplastic stroma. This is H&E section of the pancreatic ductal adenocarcinoma. It is surrounded by huge stroma, which is very active with inflammatory cells. And stroma and tumor cells both produces a number of different cytokines, chemokines, and growth factors that are important for the very strong tumor stromal interactions that are important for pancreatic cancer growth, progression, and also therapeutic resistance. So as Christine already mentioned, so I'm not going to spend any more time on this, that, that there are 5-year survival in about 20% of the earliest stage resectable patients, and there are several prognostic clinical factors that are associated with survival in the resected cases, for example, stage grade, lymph node spread, resection margin, but we do see variable outcomes that with a similar stage resection margin, we see different outcomes of the disease. So one of the hypotheses, as I mentioned, is that molecular differences in tumors determine patient outcome. So tumor heterogeneity and molecular subtype. So as I mentioned, and I will briefly tell you that this is the first study in which Fogelstein group showed by doing a comprehensive genetic analysis of about 27 pancreatic ductal adenocarcinoma, and they found that each tumor had on average about 67 genetic alterations, and that together altered 12 core oncogenic signaling pathways. But each of these tumors had a different gene mutation that was responsible for derailing or activation of these oncogenic signaling pathway, showing that it's highly heterogeneous. So based on this premise, there was many study, and this is the first study that was done by Collision et al. In 2011, based on the gene expression profiling. They discovered 3 different subtypes with different prognosis, as you can see, and they termed it exocrine-like, classical, and quasi-mesenchymal type of pancreatic ductal adenocarcinoma, and quasi-mesenchymal was the most aggressive subtypes. So after this, there were many validating study with a very huge number of pancreatic cancer cases. This one contains about 450 samples, and they also discovered 4 different subtypes. 3 were very similar to what was discovered earlier, and they also found an immunogenic subtypes, and they found that in the subtype that was highly aggressive, many of the metabolic genes that controls metabolism were altered, and also the inflammatory genes that were where the expression was altered in these subtypes. And this is one of the most recent study where they virtually differentiated between the stromal gene expression and the epithelial gene expression, and what they reported that is based on the stromal gene expression, if they categorized into active and and normal stromal gene expression, and the active stromal gene expression subtype was again with the poor prognosis. And then based on the metabolomic profile, they identified 3 different subtypes. One was slow proliferating, one represented the alteration in glycolytic pathway, and then in lipogenic pathways. And they found that glycolytic subtype was identical to quasi-mesenchymal with very poor survival, and lipogenic was similar to the classic as discovered earlier. So when we are talking about metabolic profile, this is very complicated slide, and I will just made 2 points, and one is that there are alteration as in other cancer in the glycolysis pathway and also TCA pathway. But the unique feature of the pancreatic cancer is that they have a non-canonical glutamine metabolism that involves GOT2 and GOT1, and that involves the formation of aspartate that comes out of the cytosol and leads to the formation of pyruvate, and this is for the generation of NADPH. So they use this glutamine metabolic pathway for maintaining the redox balance in the tumor. Also, it enhances the non-oxidative part of the pentose phosphate pathway for generating the building blocks and synthesis of RNA and DNA. So in one of the latest report from Alec Kimmelman, they defined the stromal and tumor interaction in terms of metabolic support, that pancreatic stellate cells, which is one of the important stromal cells that maintains stromal growth and desmoplastic nature of the stroma. In fact, they support tumor cells by producing alanine and supplying alanine to the tumor cells for the generation of pyruvate and fueling the TCA cycles. So this is very novel because there are certain controversy regarding the inhibiting targeting stroma, because that sometimes can be bad for restricting tumor growth. So this way they are saying that a stromal metabolic pathway that supports tumor cells can be targeted. So here is what they have shown, that tumor cells, and what we don't know, that how tumor cell activate the pancreatic stellate cells to increase the release of alanine. So this happens through the induction of autophagy in pancreatic stellate cells, and as I mentioned, it produces alanine that supports TCA cycle, lipid and non-essential amino acid biosynthesis, and shunts glucose to serine glycine biosynthetic pathway. So talking about stroma, there are many alterations that takes place in a stroma and the stromal environment that supports tumor growth. These are the tumor epithelial cells that induces many chemokines and cytokines that produce an immune suppressive environment by enhancing the T regulatory cells, tumor-associated macrophages, and myeloid-derived suppressor cells that inhibits CD8 positive T cells in pancreatic cancer. And it also activates pancreatic stellate cells, which is very important for maintaining stroma. And as Christine mentioned, these tumor cells also enhances the deposition of hyaluronic acid that enhances the interstitial fluid pressure and constricts the vessels in the tumors that inhibits drug delivery. So as we know that it's a problem of delivering drug regimens to the tumor, and many of the studies that has reported enhancement in the drug delivery by targeting stroma, they have used this KPC mouse model of pancreatic cancer. I would just like to say a sentence because many of you may not be familiar with this model. This is a KRAS mutant, P53 mutant mouse model that is pancreatic specific, and it enhances and it develops pancreatic ductal adenocarcinoma and exactly mirrors the development and progression of pancreatic cancers in human. So this is the study by Sunil Hingorani, which we were talking about, the deposition of hyaluronic acid in stroma and increase in the interstitial fluid pressure that constricts the vessels. And then, as Christine mentioned, by using PEG-PH20, that is a pegylated hyaluronidase, you can remove that hyaluronic acid, and that enhances the delivery of chemotherapeutic drug, and which enhances the survival in KPC mice model, which I just described here. So as I mentioned, that there are many aspects of tumor biology that needs to be understood in order to improve treatment and improve survival, ultimately in pancreatic cancer patients. And one of the important aspects of pancreatic tumor biology are inflammatory signaling, inflammatory mediators, and immune signaling pathways. So again, I won't go into details because Christine already described about inflammation and pancreatic cancer, increased risk because of the chronic pancreatitis and desmoplastic stroma, inflammatory cytokines, and there are many enzymes that enhances the production of reactive species. For example, COX-2 and NOS2 are also enhanced in pancreatic cancer, and you do see constitutive activation of many oncogenic signaling pathway, including NF-kappa B signaling. So this cartoon shows that we see a stepwise accumulation of inflammatory changes from the generation of precursor lesions, pancreatic intraepithelial neoplastic lesions, to the development of pancreatic ductal adenocarcinoma. Also, KRAS mutation is found in almost 95% of the pancreatic cancer, but there has to be a steady level of the pathogenic level of mutated KRAS, because just KRAS mutation may not induce tumorigenesis in all the cells. So there has to be, and Craig Loxton at MD Anderson has described a couple of years ago, that KRAS-induced inflammation that also involves the activation of NF-kappa B pathway and also generation of intermediates that is produced by the COX-2, like prostaglandin E2, are important for maintaining a pathological level of KRAS to maintain its tumorigenic activity. So as you know, that a tumor cells produces a number of different cytokines, chemokines that activates some of the oncogenic signaling pathway like NF-kappa B, STAT pathway, Notch signaling pathways. And there are several positive and negative feedback loop between tumor and inflammatory cells that enhances epithelial mesenchymal transition, cell survival and proliferation, and also inhibits senescence. So one of the important element is the reactive oxygen and nitrogen species, and I'm going to talk about some of my studies which we have recently completed, and some are unpublished in the next 10 minutes, is about two inflammatory mediators. One is the macrophage migration inhibitory factor, or MIF, and the second is the nitric oxide, which is a free radicals. So MIF is a pro-inflammatory cytokine that was first discovered to be expressed in both epithelial and inflammatory cells, and it was first described to regulate the immune and inflammatory response. It is also expressed at higher level in different tumors. It enhances a number of different oncogenic signaling pathway, for example, NF-kappa B, ARK1, ARK2, and AKT, and it enhances the expression of some of the enzymes that catalyzes the reactions that can generate reactive species, for example, nitric oxide and prostaglandin. It inhibits the p53 tumor suppressive function and also interferes with the RBE2F, and it inhibits the anti-inflammatory function of glucocorticoids. So based on these and other functions, the MIF is described as a connecting link between inflammation and cancer. So we tested a simple hypothesis: if MIF contributes to pancreatic cancer progression and predicts disease outcome, we found that tumor had an increased expression of MIF, as you can see here, as compared to the non-tumor pancreatic ducts, and also an increased expression of MIF. This is QRT-PCR assay, and if it is more than median expression, it is associated with poorer survival as compared to the patients who had lower level of MIF, and this was also shown here by univariable and multivariable analysis that MIF is associated with poor prognosis. Then these observations were validated in several different cohorts, our cohorts, and also publicly available data sets, which shows that in higher expression of MIF associated with poor prognosis in resected patients. So these were just association. This is some of the orthotopic model which showed that increased expression expressing pancreatic tumors had accelerated growth and increased metastasis. And when you look at these tumors, interestingly, the control tumors showed well to moderately differentiated tumors, but every single one of the MIF-expressing tumors were poorly differentiated. And we look at the gene expression profile, they look completely different. And MIF-expressing tumors showed expression of EMT marker genes. And this report came which was consistent with our findings that MIF is associated with enhanced progression of pancreatic cancer, which showed that a stage 1 pancreatic cancer, if the exosomes in these patients have increased MIF expression, they have increased chances of liver metastasis, and increased exosomal MIF were preparing the niche for metastasis in liver. So we were very comforted with this finding that was consistent with our observation. So we went back to the patient tumors, and we categorized in 2 different groups, and we comprehensively investigated the tumor biology that was in MIF high and MIF low tumors, and we asked 2 questions: are they molecularly distinct, and what is the mechanistic and functional role of MIF in tumor progression? So the hypothesis was that MIF regulates microRNA associated with tumor progression and disease aggressiveness in patients with pancreatic cancer. We found several differentially expressed microRNA in MIF high versus MIF low, and many of these microRNAs were also associated with survival. We validated these findings in multiple cohorts of pancreatic ductal adenocarcinoma. And here are some of the findings. We found that increased MIR301B expression was in MIF high tumors, and increased MIR301B expression was associated with poor survival. Then in our further analysis, we found that one of the important targets of MIR301B is a nuclear receptor subfamily 3 group C member 2, or NR3C2 in pancreatic cancer. NR3C2 encodes the mineralocorticoid receptor, functions as a ligand-dependent transcription factor, mediates aldosterone action on salt and water balance, It was found to predict survival and disease recurrence in lung cancer and also in colorectal cancer, but nothing is known about NR3C2 in pancreatic cancer. And to cut the story short, what we found that MIR301B target NR3C2, and NR3C2 normally functions to inhibit epithelial and mesenchymal transition. So we identified that MIR301B NR3C2 signaling is important for pancreatic cancer progression, and it is clinically relevant because we found that in MIF low tumors there was increased NR3C2 expression, and MIF high tumors there was low NR3C2 expression. A positive correlation was found between MIF expression and MIR301B expression, and negative correlation between MIF and NR3C2 and MIR301B and NR3C2. Also, a lower expression of NR3C2 was associated with poor survival. This was validated in another independent cohorts, and also in the TCGA cohort, you can see that, and also another publicly available data sets. So the hypothesis is that MIR301B NR3C2 signaling is a potential therapeutic target in pancreatic cancer, and we used the KPC mouse model to genetically delete MIF, and this is the MIF deleted KPC mice. They develop tumors, but they don't have the MIF. And as you can see here, the MIF deficient KPC mice or mKPC mice had significantly longer survival and lower metastasis, as shown here. So the next step is to inhibit MIF in this model and other preclinical model for the pharmacological inhibition of MIF, which Christine and I are collaboratively working on to use either anti-MIF antibody or a small molecule MIF inhibitor in the same model, and we are using KPC mouse, we are using PDTX, patient-derived tumor xenografts, and also tumor organoid model. So we have a collaboration with Richard Bucala at Yale, who has developed antibodies and also small molecule inhibitors. I don't know how much time I have. If I have 5 to 10 more minutes, I can tell you a little bit about nitric oxide, or okay, 5 minutes? Okay. So in summary, a higher MIF expression is associated with poor outcome in pancreatic cancer patients. MIF enhances growth and metastasis of tumor xenografts in mice. MIF-driven signaling inhibits NR3C2 by upregulating MIR301B. NR3C2 is a negative regulator of EMT. I did not show you the hard data. It's just published in Cancer Research. MIF deficiency increased survival and reduced metastasis in KPC mice, and MIR301B NR3C2 signaling is a potential therapeutic target. So I will just tell you in 5 minutes about nitric oxide. Nitric oxide is produced during the conversion of L-arginine to citrulline, and this reaction is catalyzed by a family of enzyme, nitric oxide synthase, which can be constitutive, which are represented by NOS1 and NOS3, and inducible is NOS2. Nitric oxide can interact with molecular oxygen or superoxide anion and can form different reactive species that can lead to nitrosation, deamination, oxidation, nitration, which can induce DNA damage, including mutations and protein modification, which we have earlier seen. So what we have seen that, like MIF, if you have increased expression of NOS2 in the human pancreatic cancer, early stage cancer, then you have poorer survival as compared to the patients who had lower expression of NOS2 in tumors. This is just to show by immunohistochemical staining the increased expression of NOS2 in tumors as compared to non-tumor. And then we use the same strategy using KPC mice. When you delete KPC, you see an increase in survival as compared to KPC mice which has NOS2 expression. You see a decrease in inflammation as shown here by the macrophage infiltration by F480 staining. This is the NOS2 deficient KPC mice. And also you see increase in the chemokines and cytokines. This is one example of CCL2 or MCP1. And you also see a lower expression of miR21. And we and others have earlier shown that increased inflammation is associated with the increased expression of miR21. So mechanistically, what we showed is that nitric oxide induces a PI3 kinase AKT that inactivates FOXO. FOXO, which induces apoptosis, cell cycle arrest, and DNA repair, but NO-induced phosphorylation inactivates FOXO. That could be one of the mechanisms. And this is the summary, which you can see that increased NOS2 gene expression is associated with poor survival. NOS2 deletion enhanced survival in KPC mice. Pancreatic tumors in KPC mice have an enhanced inflammatory response as compared to KPC NOS2 mice. And then NOS2 NO signaling may contribute to the pancreatic tumor progression by inducing the activation of ERK signaling pathway, inactivation of FOXO3, and enhancing miR21. And as I told you earlier, we are currently using MIF inhibitors and also NOS2 inhibitors. And we are also using a combination of MIF and NOS2 to see in these preclinical models if we get the effect as we see with the genetic ablation. And after that, in collaboration with Christine, we are looking into possibility of starting a clinical trial in collaboration with a pharmaceutical company that has MIF inhibitors in the clinical trial for other diseases. So I will stop here and would like to thank many of my collaborators, because as you have seen, all the studies were done in a large number of tumors from a large number of pancreatic cancer patients. And we are very, very thankful to those donors and our collaborators, surgeons, so that we could validate our findings in multiple independent cohorts. So thank you very much, and I would like to, I would be happy to take your question. Thank you very much.
That's very exciting. Well, I hope we have anybody who hasn't asked a question. You want? Yeah, okay.
So I have several very simple questions. One, do you have any connections, or do you know about any connections between MIF and cachexia produced by pancreatic cancer? So that may be a very interesting one.
It has not been done, but that is a very important question, and we are thinking of doing that because there are models, mouse model, including KPC mice, that develop cachexia.
Okay. Second question is, nitric oxide is induced by hypoxia.
That's right.
So basically, you have indication those tumors that are hypoxic, so they have poor prognosis. So it just serves as an indicator of the more hypoxic as opposed to.
Exactly. And also, so in addition to NOS2, enhancement of NOS2 expression in hypoxia also enhances MIF. So that makes it more interesting.
Okay. Yeah. And the last one is, what is the cause of death of pancreatic cancer patients?
Yeah, so all these data that I have shown, they were cancer-specific mortality.
What do they die? Well, I think Christine showed
Christine will
the slide
tell
what the problems are.
Is there a difference those that treated as opposed to those that are not?
So that I can't answer all that well, because a lot of times people that aren't treated at all, there's not enough of an evaluation before they get sick and die to really know what they're dying from. You know, I think that we like to think about pancreatic cancer patients dying from liver metastasis, really. So over 50 to 60% over that of pancreatic cancer patients end up with liver metastasis, and that can become Right. So that can become a significant burden. It's not just loss of function, but there gets to be the point where if you disrupt a number of different small biliary tracts, that you can't stent them anymore. And so you get jaundice and liver dysfunction. But there's definitely a group of patients that die with a burden of disease that's far less than what you would expect. And there's a thought that there's this cachexia, these blood clots that patients get, the weight loss, the pain syndrome, all of that is a paraneoplastic process, meaning the tumor is making something that's causing this to happen, and that those things in and of themselves kill patients, and that they basically waste away even in the absence of having a huge burden of liver metastasis. And it's not well understood, but there's a good bit of research going on to look at that now.
Are there other questions? Yes. Wait a minute, wait a minute, wait a minute, wait a minute.
Very interesting presenter. You indicated that diabetes is a factor, a minor but a factor. But there are two types of diabetes, diabetes 1 and diabetes 2. So is there any differentiation
two.
between them?
So the short answer to your question is I don't think so. But it's hard to say because that's not my field of expertise. The bottom line is that if you've had diabetes for a long time, meaning 10 or more years or 20 or more years, you have an increased risk of pancreatic cancer. Separately, there are patients who are diagnosed with diabetes and are thought, in their 40s, 50s, 60s, and then within the next 2 years are diagnosed with pancreatic cancer. And so there's people with long-standing diabetes have a higher risk of pancreas cancer because of the inflammation that diabetes causes in the pancreas. But the reverse association appears to be true as well, where diabetes itself and that onset can be a harbinger of pancreatic cancer to come. And it's estimated that somewhere a little bit less than 5% of patients who are newly diagnosed with diabetes, in their middle years, they're actually not really type 2 diabetics, as everyone would assume, but that they have pancreatogenic diabetes from what's going on with pancreatic cancer that's developing. And that's actually one of the patient populations that's being targeted for screening with testing biomarkers as newly diagnosed diabetics, because there's a real number of those patients who may actually have pancreatic cancer.
So let me ask a question here. In your view, is the inflammatory, seems as if the inflammatory response is hypothesized to be a response to the presence of the tumor. To what extent are there models that examine the notion that the complicated inflammatory response is pathogenic?
Yeah, I think it's both because KRAS mutation itself induces inflammation, and mutated KRAS in the cells can induce a inflammatory microenvironment that can increase that enhance the development of a preneoplastic cells, and then their progression into neoplastic cells. Once the tumor develops, the tumor itself induces inflammation and inflammatory signaling pathways, and their interaction with the stromal cells that enhances signaling pathway that help in the progression and metastasis. So it is both the development and progression.
So maybe you'd like to comment about the concept of angiogenesis control in both the pathogenesis of metastases and so forth, and treatment.
Yeah, so angiogenesis is especially in pancreatic cancer, it's hypovascularized. Mm-hmm. That is one of the characteristics, both in the at least in the animal model, it's highly hypovascular, and if I am correct,
it's true in people as well.
And it's true in the people too. So many of the anti-angiogenic regimen has not worked very well in clinical trial. That could be one of the reason because there is not enough angiogenesis that is important for the pancreatic cancer progression and
In
survival.
fact, the question that's asked a lot of times with pancreas cancer as opposed to other tumors is how does it actually get its nutrients
Yeah.
because it's so hypovascular? And one of the things that's been in the literature over the past few years that's really interesting is this idea that it eats its own stroma, that it like it breaks down that huge stroma and that collagen matrix and all those other things, and then endocytoses those amino acids inside to actually feed itself is one of the more interesting things that have been coming out of research recently because it is so different from other tumor types in that regard.
So maybe we might ask, how often are pancreatic tumors actually expressing the capacity to make proteolytic enzymes and lipases?
So if you're actually talking about like the dietary, like your usual exocrine pancreatic function where you have digestive enzymes, I don't frankly know the answer to that question. As in, I've never looked at the literature to say, has somebody measured that? What I can tell you is that the majority of my patients, even if they haven't had surgery for pancreas cancer that's removed part of their pancreas, if they just have their primary tumor still in place and all that, the majority of those patients need to be on supplementation for those enzymes because they're either not able to get them out of the pancreas or they don't make enough of them. So presumably most pancreatic cancers don't make a lot of them, but I couldn't cite you the literature
No,
to
but I
show
think the
that.
point is not that they make, there is older literature that says 25, 30 years ago, showing that pancreatic cancers, many of them do synthesize various proteolytic enzymes and lipases. Now, not sufficiently to provide nutritional digestive function, but conceivably sufficient to feed into inflammatory responses as a response to these
I see.
proteolytic, and that may
That's
actually be a
interesting.
factor in facilitating the inflammatory
The
response.
stroma of pancreatic cancer is classically called one of the wounds that does not heal, where you were talking about before, this wound response. And it's thought that a lot of those pathways, which go through a TGF beta 2 signaling, is actually a misdirected wound healing process
Yeah.
that the cancer triggers. I think one of the interesting things about it, is,
Yeah.
if Pervase has done, is starting to do this work with these organoid cultures where you have tumors that are taken out, or even pancreatic patient-derived xenografts where they patient tumors and you put them back into mice. And even though, these organoid cultures are just the cancer cells and not the other stromal matrix that goes with it, just the fact by putting them in the right place, they call all those other cells back in. So there's something that they're making in and of themselves that causes that environment and that, that gets it started.
And also, Christine mentioned about the TGF beta and the stromal activation. In fact, MIF is taken up by the Kupffer cells, and that enhances or activates TGF beta, and then that activates pancreatic stellate cells. That was the Nature Cell Biology paper which I showed by David Leiden, and he will be speaking, I think, in March in the metastatic niche symposium.
Okay, well, listen, I want to thank you both.
No,
for a very
he had a
interesting-
question.
Is it possible or someone is working on a set of cytokines specific for pancreatic cancer? Because these are inflammatory response like interleukin-6, interleukin-1, TNF, TGF-beta, to make, a kind of kit that would allow to make diagnostic to say, okay, so that person probably has inflammatory response to pancreatic cancer.
There are many biomarker studies that have been pursued to like IL-6 and IL-8, IL-1 beta, but the problem is that they are also expressed heavily in pancreatitis patients.
Yeah.
So it's very hard to make a differential diagnosis. But again, even if it is expressed in the pancreatitis patients, but not in 100% of the patients. So those pancreatitis patients who have very high expression of, for example, for IL-6 or IL-8 can be followed up closely.
All right. Well, thank you again, and thank you very much for participating, and we wish you all the best in the world. Wonderful. Thank you again. Thank you.